This episode of Transmission Interrupted was recorded September 20th, 2024.
This is Transmission Interrupted, the podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Welcome to Transmission Interrupted from NETEC.
Hello and welcome to Transmission Interrupted. My name is Jill Morgan. I am on the biocontainment team here at Emory University Hospital in Atlanta. For those of you not yet familiar with NETEC, our mission is to set the gold standard for special pathogen preparedness and response across health systems in the U.S. with the goal of driving best practices, closing knowledge gaps, and developing innovative resources. NETEC works alongside and in cooperation with the CDC and is funded by ASPR, the Administration for Strategic Preparedness and Response. I love learning about pathogens and infectious diseases that I may have heard of, but I don't know a whole lot about, and I am very excited today to talk about dengue. So dengue is a mosquito-borne virus from the same viral family that includes things like Zika and West Nile and yellow fever, Flaviviridae. And while Zika and West Nile are sort of the newer kids on the block, dengue and yellow fever have been around for a long time. So sometimes these diseases can be super mild and even asymptomatic, but severe illness is possible, and it's estimated that worldwide about 5,000 people die of severe dengue like last year. So we're here today to talk with the CDC expert on dengue, Dr. Joshua Wong, and to spread the word that dengue is something that we should all be on the lookout for and why. Dr. Wong is a medical officer and epidemiologist with the Centers for Disease Control and Prevention, stationed at the Dengue branch in San Juan, Puerto Rico. He's also a lieutenant commander in the United States Public Health Service Commissioned Corps. He graduated from Harvard Medical School and completed his residency training in the Global Health Track in Internal Medicine at Stanford University. He served as an Epidemic Intelligence Service Officer at the Centers for Disease Control and Prevention's Dengue branch. After his fellowship, he remained at the branch to continue working on dengue vaccine activities and to support the emergency response to dengue both domestically and abroad. So welcome to the show, Josh.
Thanks so much for having me.
Absolutely. So let's just kind of dive into just the basics for dengue, how it's transmitted, and maybe a little bit about what sort of drew you into dengue.
Yeah, thanks for asking. Dengue, my favorite topic. The reason I was drawn to dengue was really, I did my medical training always with an eye towards global health and neglected tropical diseases. As you said in my intro, I did my residency at a really fantastic global health program at Stanford and was able to work in hospitals in Colombia and Uganda during my residency. And that's where I really saw that we could have a lot of impact if we addressed neglected tropical diseases. And so that was why when I got to CDC to do the Epidemic Intelligence Service program, these 2 years, I was looking at a lot of different places, and dengue branch really was a natural fit. It's located in Puerto Rico. You know, this is a neglected tropical disease, but one that actually presents a real problem to U.S. territories and the freely associated states. It was such a natural fit to be at dengue branch that I decided to stay on for an extra couple of years. So here I am.
I think that's great. So you mentioned Puerto Rico. Where else is dengue an issue? Is this something that we need to be concerned about on the continent, in places like Florida and across the Caribbean, or where is sort of dengue's reach right now?
Thanks for asking that question, because dengue is a huge problem and it's bigger than it ever has been. Globally, data from WHO would say that there have been more than 12 million cases around the world and 37,000 severe cases. And there were greater than 8,000 dengue deaths in 2023. And so far this year in 2024, we're getting close to 8,000 reported dengue deaths. And we're not even finished with the year. So it's a huge problem. It's a huge problem in the United States as well. Dengue is a nationally notifiable disease, and it has been since 2010. And this year in 2024, there have been more than 5,027 dengue cases reported in 50 jurisdictions. And, you know, it's a really important thing to get a little bit deeper into those numbers because in Puerto Rico, there is currently an ongoing public health emergency due to dengue. So when I talked about those 5,000 dengue cases, there were 3,277 that were locally acquired. And of those, 96% occurred in Puerto Rico. So, you know, it's a big issue where our dengue branch is sitting right now.
Wow. And I just saw this week cases in Los Angeles. So It's so interesting that whether it's because of warming or because of travel or because of storms and other things that bring mosquitoes with them, we're seeing more and more of dengue. So let's take just a second and back up and make sure people understand sort of where dengue comes from, sort of what the life cycle is. And then I'd love to dive in to how we might actually think about this in a healthcare setting in the United States, what things people should be looking for so that you can keep dengue and other things like it on your sort of differential diagnosis list.
I can give you a little bit of the background about dengue right now, and this is sort of a primer that I always give to docs when I'm doing clinical trainings on this. Dengue viruses are mainly spread to people through the bite of infected Aedes species mosquitoes, and that can include Aedes aegypti or Aedes albopictus in the United States. And there are other less common routes of transmission besides mosquito bites. It can be transmitted perinatally. It has been found in breast milk. In laboratory healthcare settings, exposures through blood transfusions or transplants or needle stick injuries can occur. And there's some evidence suggesting that dengue can be spread through sexual contact. But I do want to drive home that most cases of dengue are going to be due to mosquitoes.
All right. So dengue is primarily, at least, a mosquito transmitted pathogen. What does it actually look like for a human to have dengue? And I know that there's a difference between maybe a separation of sorts of dengue and then severe dengue.
Sure. So there are 400 million dengue virus infections around the world every year. Only 1 in 4 of those infections are actually going to be symptomatic. And that means that the vast majority of people are going to have asymptomatic infection with a dengue virus. And among those people who actually get symptomatic, those 1 in 4, we say of those people, only about 1 in 20 are actually going to go on to develop severe life-threatening complications. And what it would look like for those who are going to be symptomatic is that once you're bitten by an infected mosquito, typically it's going to have an incubation period of about 5 to 7 days. And then the early clinical findings are really going to be nonspecific. You need to have a high index of suspicion for dengue because it's not a disease that most US-based clinicians are normally going to see. It's really going to be a disease of returning travelers unless you're in areas like Puerto Rico where there's an ongoing large epidemic. And those nonspecific signs are going to present at the very beginning, but then later on in illness, the fever progresses, then you're going to start seeing things that might herald that you're going to have severe disease. And those things are warning signs, and we can talk about those a little bit later. There are some very common laboratory findings such as leukopenia, thrombocytopenia, and sometimes you can see elevations in liver enzymes too. So that febrile period is going to last typically 2 to 7 days. You might see a biphasic fever. You can also have things like a severe headache, myalgias, arthralgias. Retroorbital pain is an interesting symptom because that's one that can be unique among dengue patients. And then also you're going to see rashes during the entire clinical manifestation of the illness. You can also have rashes with dengue that will take different forms at different periods in the illness. So early on, sometimes you'll see flushing at the very early onset of the disease. And then later on during the febrile phase, you can have maculopapular rashes that will start centrally moving outwards. And then later on during disease, after you've gotten past the critical period and are in the convalescent phase, you can really see the classic islands of white in a sea of red. I know that we've all read about this in medical textbooks. So there's a lot of different interesting rashes that you can also see with it.
Wow. All right. So fascinating. I'm really interested in some of the sort of key elements that can help like an ED physician start to be able to winnow through some of these things. A complaint of fever and headache can be so many things. It can be really hard to get specific. And without testing somebody, as people wish that we could, with just test me for everything, I wish that we had that. What does testing for dengue look like? Who does it and where do they do it and what kind of specimens are sent for testing?
Yeah, laboratory testing for dengue is something that we think a lot about here at CDC because it really is an important part of disease surveillance. So one thing I do just want to clarify here is that dengue as an illness is one that's going to have nonspecific clinical findings at the beginning of disease. There can be these little clinical clues like we were talking about, thrombocytopenia, leukopenia, but they don't always necessarily need to be there. And they can also really overlap with a lot of other illnesses. So really, I think the most important part when you're evaluating a patient who has returned from travel is really to do a good history and physical and get a good exposure history. Were they in a country where there was a recent dengue outbreak, where there's known dengue transmission? And these are things that you should always be attuned to. Now for testing is a really important part of surveillance, but the turnaround time sometimes can be such that they're not going to impact your clinical management of the disease. Clinical management should be based on a high index of clinical suspicion, based on your travel history, and based on the presentation of the patient. And we can get into a little bit more later about the treatment and why that can be really important. But we are encouraging all physicians to be testing. That testing is available through your state and local health departments. And the types of tests that they're going to run, or the types of tests that you should order, will vary depending on the time of the presentation of the patient. And what do I mean by that? So if a patient presents with a fever between days 0 and 7 of that fever, that's when you're actually going to have viremia, as well as an increasing IgM. Typically on days 3 to 5, it's either going to be an RT-PCR for dengue and an IgM, or an NS1, which is a non-structural protein that is a viral byproduct of viral replication. So that one and the IgM. So doing these two tests together, the RT-PCR or the NS1 and the IgM, has a sensitivity of about 90% for dengue infections during days 0 to 7. Typically, the fever is going to be present for the first week. That's usually when patients are going to be coming to you. But if you do have a patient who thinks that they might have dengue and they come after day 7, typically we recommend an IgM test, but you can also still consider doing an RT-PCR and NS1 test, because those can be less problematic with the issues of cross-reactivity with other flaviviruses. And if they're still positive, they'll help you make that diagnosis.
So really thinking about like the difference between the person we might think about on their ED presentation versus the person who might have been in our hospital for a few days, and finally somebody gets an infectious disease consult and the infectious disease doc says, wonder if this could be dengue.
Exactly. Yeah.
Yeah. So clinical course, I understand we've sort of winnowed this down from a large number of people who might get dengue and never even know it because they had an asymptomatic course, recovered on their own. A small proportion of those people will actually get ill enough to seek treatment. And we know that a lot of those folks are going to get better with just supportive care and symptom relief. And then there are those that are going to end up with severe dengue. But what does the course of severe dengue look like? What are we talking about?
Yeah, and I'm really glad you asked this question, because I want to explain a little bit more about what you can expect to see with dengue and sort of how to know if your patient is going to go on to have severe dengue or if they're at risk for severe dengue. So, as we said, after the incubation period of 5 to 7 days, there are 3 phases to dengue. There's the febrile phase. Patient has a fever. After the fever falls, they might go into the critical phase. And then after that, then they're going to have the convalescent phase. And let me explain what I mean by these. So like we were saying, the febrile phase, typically 2 to 7 days, you'll see that biphasic fever sometimes, and you're just going to see pretty non-specific signs and symptoms that are common to a lot of different infections. The headaches, the myalgias, the arthralgias, sometimes those rashes. Sometimes you might see minor hemorrhagic manifestations like petechiae, ecchymoses, and these are all going to be really non-specific things. So the interesting thing with dengue, though, is that towards the end of that febrile phase is when a patient is going to decide whether they're going to go on and get better or whether they're going to go on to have severe dengue. And how can you know that? When the fever falls, if patients start having warning signs, that's when you know that they might be at risk of progressing on to severe dengue. And so those warning signs are a really important thing that we always teach clinicians about. So you have to be attuned to knowing that when the fever is about to go down, you have to be asking the patient, knowing when their last fever was, and then you have to ask and screen for these warning signs. And there are 7, which I'm going to talk about right now, but in case you forget them, we actually have a wonderful CDC pocket guide that's posted on our website. So the 7 warning signs are intense or continuous abdominal pain or tenderness, persistent vomiting, and the definition for that is greater than or equal to 3 episodes in an hour or greater than or equal to 4 in 6 hours. Any sign of fluid accumulation, pleural effusions, ascites, or pericardial effusions that you see either on imaging or on physical exam. Any evidence of mucosal bleeding from the gums or the nose, those can be the sneakier ones that can be rather subtle, or heavy vaginal bleeding or macroscopic hematuria, which are going to be a little bit more obvious. Also, altered mental status, such as irritability, drowsiness, or a less than perfect Glasgow Coma Scale, hepatomegaly, or a progressive increase in the hematocrit or hemo concentration. And I think that that one is actually particularly important because it speaks to the pathophysiology of dengue. So after the febrile phase, when someone is going into possibly severe dengue, there's sort of two ways that people can get to severe dengue. There's either plasma leakage or bleeding. And plasma leakage is the process by which you actually have extravasation of this protein-rich fluid from the intravascular space into the extravascular spaces. And that's why you can see things like pleural effusions, ascites, or even pericardial effusions, which are less common than ascites or pleural effusions. But when you've got that clinical fluid accumulation, you'll also start to see hemoconcentration. And that can be one of those earlier signs that you might be sliding into plasma leakage.
I think that that's fascinating. And I'm wondering, thinking about the other things that we're probably going to be ruling this person out for, things like malaria and the crossover with pathogens like that, where this can be a really confusing clinical picture to try to figure out which one came from what. And at one point, I guess it really doesn't matter. You're just going to be trying to rule out these things by testing them. So, like doing a Binax, getting a rapid malaria test back and then saying, okay, so if it's not malaria, what else might it be? And dengue should certainly, sounds like, be on our list.
Absolutely. I think that's a really important point, that once you've ruled out other illnesses that this could be for the person returning from travel with a fever, then you need to really be thinking about dengue. And the important part about this is that a lot of illnesses we think of as once they're over the fever, they're much better. That's not the case of dengue. If you've ruled out a lot of other diseases, you think that this could be dengue, you need to be really watching after that fever falls, immediately after that fever falls, because this plasma leakage that I was describing can really occur over the course of hours. So if people start having these warning signs, they need to go immediately to a hospital.
Wow. All right. So I want to go back just for a second to the presentation. I think sometimes we don't always appreciate that some pathogens can look different in different populations. So does dengue present the same way in adults as it does in children?
I think once again, this is going to be a hard one for clinicians, but signs and symptoms are really nonspecific to begin with. Some of those early lab findings, leukopenia, thrombocytopenia, those can occur at different times in illness and may or may not be there when a patient first presents with that sort of high fever on days 1 or 2, and they're afraid because they think they may have come back from travel with something. And typically those nonspecific signs and symptoms are pretty much the same in adults as they are in kids. One of the things that can be really telling about dengue is going to be that after the fever falls, people can start to feel worse if they're going on to have severe dengue.
And that would apply to kids as well.
Correct.
And wow, to me, pediatric cases and fluid volume, that are so important. You have a kid that's vomiting, thinking about those 7 warning signs you gave us, a child who's having repeated vomiting, and this idea of leakage of fluid into these spaces could end up with a kid who needs critical care support pretty quickly.
Absolutely. That it's a really important point that fluid resuscitation is the cornerstone of dengue clinical management. There's no antivirals available, so it's really recognizing that illness early and then starting to treat it. And I want to talk a little bit about the treatment of dengue because I think that it does have some unique aspects to it compared to other infections or even other conditions that you might think about. And that is that, so you're febrile, the fever goes down, you start to have a warning sign, and in the course of hours, you can start going south and getting sick. So the most important thing to recognize is that this critical period is going to last for 24 to 48 hours. So we typically tell people the time to watch patients who you think might have dengue is 48 hours after that fever falls. And during that time period, if they have warning signs, they have evidence that they might be at risk for severe dengue, you need to start treating according to the WHO fluid resuscitation protocols for dengue, which are extremely specific. And the reason that they're so specific is that they sort of start at a relatively high fluid rate for a couple of hours, and then you have to do a lot of reassessing of the patient. You reassess, you turn down the fluid. You reassess, you turn down the fluid if they're getting better. And it requires a lot of reassessing and then turning down the fluid rates and fluid rate management because it's a 48-hour period where they're at risk for that. And after that 48-hour period, people get better. The unfortunate part about then reactivating all of your vascular tone is that all of that fluid that was going into the extravascular space goes back into the intravascular space. So sometimes if you've not been following the protocol, you've been a little bit too liberal with fluids during that time period, then all of that extravascular fluid is going to go back into the intravascular space and can lead to fluid overload. All that fluid is going to come back and then you end up hypervolemic. You can have, once again, pleural effusion. You can have just a lot of lower extremity edema, and that's going to also take a little bit of time to get off. The way to avoid that is to stick very closely to those protocols from WHO that are in our CDC pocket guide that are going to be very specific about the amount of fluid to put in, how to slowly march it down, and how to continue to watch for those warning signs during the 48 hours that someone's at risk of sliding into severe dengue.
Right. In other words, you don't want us to just use the ICU protocol of fill them with fluid until you have to increase their amount of oxygen on their ventilator.
Or else you're going to be increasing that amount of oxygen right when they start to reabsorb all that fluid.
Yes. No, I think that sometimes we just do go overboard with some of these things. It sounds so good to just fluid resuscitate somebody, but it sounds like with dengue, we need to be very, very careful during that particular time. I want to ask you a couple more things about, first of all, besides fluid resuscitation, we don't have any antivirals or anything that's going to help us get through this?
There are no antivirals for dengue. We are really crossing our fingers that science advances and that there will be more treatment options in the future. But right now, we don't have any of those. But the cornerstone of dengue care is excellent clinical management. And I do really want to give a plug for those WHO protocols because severe dengue in some outbreaks can have a case fatality rate as high as 14% if it's left untreated.
Wow.
With these WHO protocols, we can bring mortality down to less than 1%, which is what we see from the clinical trials. And so, it's really amazing that we have these protocols as long as we stick to them.
Excellent. All right. So another question about this. So I'm thinking about all the people who get bitten by mosquitoes and all the people who travel to places where dengue is a risk. At least, could you tell me that if I get dengue and have an easy or asymptomatic case, am I immune moving forward?
You are to that specific dengue virus. And so this goes a little bit to the virology of dengue. So dengue is the disease that's caused by any one of 4 dengue viruses. So among these 4 dengue viruses, once you get infected with one virus, it's going to give you lifelong immunity to that specific dengue virus. So if you get infected with dengue 1, whether it's symptomatic or asymptomatic, you're not going to get infected with dengue 1 again. It only gives short-term cross-protective immunity to the other 3 for a matter of a couple months to a couple years. So you can get dengue up to 4 times in your life.
All right. That is just not great news. I was really hoping that I was going to just be immune if I had gotten it once. I want to talk a little bit more about the places people should think about. So we really like to drive home this idea of identify, isolate, and inform, about asking people about their symptoms and then their travel history. But sometimes we restrict that questioning about their travel history to like, have you been someplace outside the United States or to someplace specific? And we are only really thinking about these other rarer pathogens if someone says, well, I came back from, typically a country in West Africa or Central Africa. So tell me more about sort of where we should be thinking about dengue as being a possibility. I know you mentioned Puerto Rico. And then things about, I know there were some cases in Florida, and I'm wondering about sort of what are the lessons that we can learn from this kind of dengue experience now?
Sure. When we think about risk for dengue in areas of the world where you might have a risk for transmission, I think 2024 and 2023 is really a telling story. There is more dengue in the world than has ever been reported since reporting began. For example, reporting began in 1980 to PAHO, the Pan American Health Organization. And since then, 2023 was the highest year on record, and 2024 quickly overtook that. There are now more than 12 million cases in the Americas reported back to PAHO. And that really means that kind of everywhere is a risk, right? And WHO has reported that there are 103 countries or territories that are reporting cases, and this is in all 6 WHO regions. If you really want to get in there, though, and pinpoint and understand where U.S. travelers are seeing higher risk, one of the best resources for this is actually CDC's website, their Travelers Health website. And there is a dengue travel health notice out. It's a level 1, so it's practice usual precautions. But if you go onto the CDC website and look at that travel notice, you can actually get a list of all the countries that CDC has identified where there's a higher than expected number of dengue cases among returning U.S. travelers. And so that list is kept up to date and can be really helpful when you're thinking about where someone came from, about what their risk for dengue might be. But, don't rule it out for almost anywhere that someone's been, because with all 6 WHO regions and 103 countries, it's in a lot of places.
And do we need to think about it even if somebody hasn't gone anywhere else? Like, what are the odds of us having locally grown cases, if you will, from places like Florida or California or Texas?
Yeah, thanks for asking about this, because I know this is a real concern that we're getting from especially the U.S. states. And I think there is a lesson in this from Florida. Looking at the epidemiology of dengue in the United States, I think the most important thing to remember is that most cases in U.S. states are travel associated. So far in the United States, among the locally acquired cases, there are only 2 U.S. states, California and Florida, that have had locally acquired cases. And 96% of locally acquired cases are occurring in Puerto Rico. So the vast majority of patients in dengue in U.S. states are going to be travelers returning with it. Is there a risk of local transmission? Well, yes, there is. If you have a competent vector, such as an Aedes species mosquito, and then you have introductions, typically from travelers, then there is always going to be a risk that there could be forward transmission. What we see from Florida is that there are many introductions amongst travelers into an area that has lots of vectors that can transmit this, but all we really see are small chains of local transmission linked to a couple of the cases. So while it is a possibility that it can occur in any state, we don't expect that there's going to be large outbreaks. And that's what we've seen in Florida.
So really the answer for just the general population of people trying to avoid getting dengue would be to do good mosquito control when you're traveling. So wearing an appropriate repellent, using mosquito netting wherever you're traveling, making sure you're not putting yourself at risk in places that might have endemic dengue by letting yourself go camping without the right bug repellent on. And then for our healthcare providers, when somebody comes into emergency department or your clinic with fever and headache and this history of travel to some place where there might be mosquitoes, there are probably a bunch of things to test them for. And dengue should certainly be one of those on that list. So if you're thinking about malaria, you should also probably be thinking about dengue. And then one of the other nuggets I seem to be drawing from this, Dr. Wong, is that I really need to pay attention when somebody seems to be getting better. Because if this is going to go into severe dengue, I only have a short period of time to really seriously intervene and rescue that before a patient could take a serious turn the wrong direction.
Absolutely. I think that those are all really important parts of dengue care. And another thing that we always recommend to physicians and that we do a lot of counseling around is that as physicians, we need to be aware about this, but also we need to be counseling our patients. We need to be using that close relationship that we have to drive home those 7 warning signs that people might see. And I know that our website has some information for clinicians on how to do this, but working directly with your patient, working directly with your support staff to educate that if when your fever falls, you see any one of these 7 warning signs, there's about 5 of them that actually patients can really look for, the lab stuff you're going to have to do. But telling people to watch out for this when your fever falls and to come back to the emergency room, come back to the hospital immediately is a really important part of making sure that we're catching those dengue cases that might go on to severe disease. And the other thing too is that a lot of us working in the primary care arena might be doing sort of travel medicine consults. And, I think that's a great moment for us to drive home all of the points that we put in a recent health alert network, but telling people they need to prevent mosquito bites, use those EPA approved repellents, wear loose fitting long sleeve pants and shirts, And if you can, while you're traveling, staying in an area that might have screens or might have air conditioning, and certainly seek that medical care if you get sick while in country, or seek care in the US if you get sick when you're here.
Fantastic. All right. So I typically have one more thing in my arsenal, right, to help me avoid some of these pathogens. And that's that I believe in vaccines. So do we have a vaccine for dengue? Do you think there's a possibility of a vaccine for dengue? Where are we with that?
Dengue vaccines are a quickly evolving field. In the United States, there's one vaccine available, and that's Dengvaxia, which was manufactured by Sanofi. And this is recommended by the ACIP for persons who have laboratory-confirmed previous dengue infection, live in areas where dengue is common, and are between the ages of 9 and 16. So it's a very specific group for which this vaccine is available. So for your general population in US states, this is not going to be a vaccine for them. This is available in Puerto Rico for people 9 to 16 and who have done that pre-vaccination testing that says that they've had dengue at least once.
Okay.
Yeah.
So maybe I shouldn't just pin my hopes on that.
No. This is not for people who live in US states.
Okay.
There's also another vaccine called Qdenga that's manufactured by Takeda that has been recommended by the World Health Organization in children ages 6 to 16 in settings with high dengue transmission. And so this one is a 2-dose schedule with a 3-month interval between them. And it is recommended regardless of previous dengue infection, and therefore it doesn't need laboratory testing before vaccination. This one is not available in the United States. It is available and licensed in other parts of the world, however.
Okay. All right. So I want to circle back to, we've got this person that comes in. I've been thinking infectious disease when they walk in with this fever, headache. When a person is in the hospital or in my clinic with the possibility of dengue, what things do I need to think about with personal protective equipment, with other infection prevention things? This is strictly a vector-borne pathogen as far as casual contact is concerned. I understand it might be transmitted through breast milk, maybe even sexually transmitted. But for the healthcare worker, similar to Zika, we really don't have to worry about person-to-person spread.
Correct. There's no person-to-person spread of dengue. You're not going to get it from getting coughed on through airborne transmission. That's not a reality for this disease. If you think that a patient might have dengue, it's really just standard precautions that you as a healthcare worker need to take. For laboratory workers, there are rare cases of dengue transmission in the laboratory due to needle stick injuries or other similar injuries. And so that's why dengue belongs to risk group 2 pathogens. And so if you're working with dengue, it's recommended to conduct that work in a BSL-2 laboratory. And that especially applies to labs that are doing the diagnostic testing. But there are no special biosafety requirements for dengue viruses aside from just the standard precautions as well for lab workers. And so if you want more information on risk group 2 pathogens or recommendations for work with this group, you can refer to the Biosafety and Microbiological and Biomedical Laboratories 6th edition that's published by CDC and NIH, and we can drop a link for that for you guys.
Excellent. Thanks. All right. So I want to sort of wrap up this conversation, Dr. Wong, and I would love to give you the opportunity to review some of the highlights of things you think are super important takeaways, especially for our clinicians who might be out there, whether you're an ED nurse or work in a health clinic or a public health nurse, thinking about, how to watch for dengue, and then maybe some of the other things we really need to be aware of. So sort of your top 10 most important takeaways for today.
Sure. Wow, 10. Let me see if I can count those. So the message for healthcare workers is you really should maintain a high suspicion for dengue among patients with fever and recent travel, anywhere within the last 14 days before illness onset. And those areas that have frequent or continuous dengue transmission, you can find on the CDC website or on the WHO website. And, when we think about the risk of locally acquired disease, we do know that introductions from travelers could lead to local transmission in the United States. But as we've seen in Florida, typically those are going to be smaller chains of local transmission. So even if there are locally acquired cases, we really think that the risk of a large outbreak is small. We do realize that can consume a lot of public health resources and time for investigating those cases and taking the proper measures to prevent onward transmission. So you should really be looking for this mostly in travelers. And, when you see these patients who you think might have dengue, do order the correct tests. So that's PCR or NS1 and an IgM within the first 7 days of that fever. After those 7 days, definitely do an IgM and consider doing the PCR or the NS1. Another big thing is that you have to start treating dengue if you think it's dengue before those test results come back. It might take too long for those to come back. And patients, when they go into that critical phase, when the fever falls, can get sick in a matter of hours, can start having that plasma leakage in a matter of hours. So really know those warning signs and screen for those at every point that you can. Another big one that I want to drive home here is that CDC has a pocket guide for dengue clinical management that will help you triage patients, whether they can be managed as outpatients, whether they need to be inpatient for fluid resuscitation by the WHO protocols, or whether they have severe dengue and are going to need to go down a more intense protocol list. And that pocket guide is available on the CDC website. I think the message out there for everyone, for us, for our patients, and for the public is really that everyone can play a role in preventing dengue by protecting themselves from mosquito bites. Wear those EPA registered repellents. Do wear long sleeves, long trousers to try to prevent bites. Stay in places that might have fewer vectors, places that might have air conditioning or might have window screens when you travel. And certainly around your home, you can control the vectors that might lead to onward transmission of dengue as well. Dump standing water, use window screens, take other prevention steps in and around your own home when you get back from travel.
Gosh, thanks. So I want to take this opportunity to plug again, and I think anybody who's listened to this podcast before has heard this several times now. Identify, isolate, inform is so important. Even though there's not person-to-person spread of dengue, you're not going to know what they might have unless you ask. So that travel history, that travel question that pops up on your electronic medical record, I know it's a pain. I know it seems like one more thing you have to click on every single patient, but this is why it's so important. 12 million cases of dengue across the world. We do not need to be missing these, especially when someone could have a critical illness brought on by a pathogen that needs supportive care, very specific supportive care during a critical time of that illness. So it's so important to do your symptom screening, to do your travel screening, to take a good history, and then to intervene appropriately. And understanding that, at least for dengue, that fluid resuscitation might need to look a little different than how you normally use a resuscitation protocol for your average sepsis patient. Fantastic. Well, I just want to thank you so much, Dr. Wong. It's fascinating to hear about all this. I really like the message that we should be thinking about ways we can control the mosquitoes within our own personal environment by making sure they don't bite us, but that we're not making some wholesale advocacy for mosquito spraying. Mosquitoes do play a part in our ecosystem. We understand that we can't just wholesale kill every mosquito everywhere, but we can do our part, which is to try to keep ourselves from getting bitten.
Absolutely. Agree that bite prevention is going to be the message for the public. And then for clinicians, it's recognize. Screen for those warning signs.
I love that. All right. Thank you so much. Well, thank you for joining us for this discussion on dengue. Thank you to Dr. Wong, and we really appreciate your expertise, and we will make sure that the references that Dr. Wong mentioned will be attached to the podcast so that you can look for that pocket guide and look for the other information about the WHO fluid resuscitation protocol. Really appreciate those as being things that will help our clinicians treat this appropriately and be thinking about it as they encounter returning travelers with a fever. For those of you listening at home, thank you for tuning in to this episode on dengue. We hope you'll join us for future episodes on a wide range of topics, from healthcare worker safety to personal protective equipment and infectious diseases of all kinds, including things like dengue that don't have person-to-person spread in traditional settings. If you have questions for NETEC or ideas for future shows, please feel free to contact us at info@netec.org or find us on the web at netec.org/podcast, where you can subscribe to future episodes and find more information on today's topic, including those links. We'll see you next time on Transmission Interrupted.
You've been listening to Transmission Interrupted, the podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Learn more at netec.org.